Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist, professor and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team and am the host for Emory's health videos, where for the last 2 years, you've heard me mostly talk about COVID-19. But today we are turning to a new epidemic, monkeypox. I am pleased to be joined by my friend and colleague, Dr. Carlos Del Rio, for this conversation today. Welcome, Dr. Del Rio.
Happy to meet with you.
Thank you. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health here at Emory University, and is the executive associate dean at Emory University School of Medicine at Grady Health System. So as a quick reminder, because we cannot go through a video without talking about COVID-19, here is where we are right now. With COVID-19, we are averaging 125,000 cases a day of new infections in the United States. This is thought to be an extreme undercount of where we actually are based on the level of at-home testing that people are doing. And why we're bringing this up is the fact that this is more than double where we were last year at this time, and we are about to see our kids start back to school. Additionally, 42% of the country is in a county where the rates are high enough that the CDC recommends indoor masking. So as we look at counties across Georgia, particularly here in Metro Atlanta, almost everyone is living in a place where we should have indoor masking. And so we want to remind you of that as we begin to talk about a new epidemic, monkeypox. So turning to monkeypox, the WHO declared monkeypox a global health emergency just this week. Since early May, the US has diagnosed a total of 3,487 cases of monkeypox, with more than 18,000 globally. As of yesterday, the United States had more cases than any other country that is not endemic to monkeypox, and cases have been reported in more than 30 countries across the world, again, where we don't normally see this virus. Outbreaks are most common in at least a dozen countries in West and Central Africa. So we're talking about cases beyond those areas where we would normally expect to see it. Additionally, Georgia is in the top 5 states for monkeypox cases in the United States currently, according to the latest CDC data. The vast majority of cases that we are seeing in this current outbreak with monkeypox are among men who have sex with men. And we're going to be talking about that very specifically during our time together today. So Dr. Del Rio, let's start with transmission as we start this conversation about monkeypox, because the conversation about transmission can really be fraught with stigma and misinformation. This virus can spread and does spread person to person through direct contact, with both contact to an infectious rash, scabs, bodily fluids, prolonged face-to-face contact, or during intimate physical contact. But as we see this epidemic spreading most quickly among the community of men who have sex with men, the gay community, sexual encounters clearly play a role in transmission. Is this a sexually transmitted infection?
Well, let's start by saying that, what we knew about monkeypox up to now is fairly limited and is very hard to use what we knew before to what is happening right now. What we knew before about transmission from monkeypox comes from, as you said, from experience in Africa, but also from an outbreak we had here in the United States in the early 2000s, in which Gambian rats infected with monkeypox were brought to this country to a pet store. And in that pet store, the Gambian rats infected some prairie dogs, and the prairie dogs were then bought by some families, and members of those families across multiple states got infected. And what we learned there is that contact with the prairie dog. So if you were bitten or licked by the prairie dog, you got infected. So there were many lesions in the hands. There were also lesions in other parts that the dogs had touched. And then the individuals transmitted to other individuals in the family. But at that point in time, it was pretty contained and nothing much was necessary. And then the epidemic stopped. And people traditionally, we all said, the transmission of monkeypox is low, and therefore it stops by itself. You don't really need to do a lot, and that was the experience, right? But what we're seeing right now is very different. What we're seeing right now is transmission through social and sexual networks of men who have sex with men who have multiple partners and multiple anonymous partners and multiple partners found online. So it's a little bit difficult to say, how exactly this is being transmitted. It's not sexually transmitted, but it's being transmitted during intimate encounters, including sex. And again, the contact with the lesions, I think, is very important. Contact with infected lesions is very important, as it is, which would happen, could happen during sex. Somebody can have a lesion in their rectal area and their genital area and not necessarily notice it and then infect somebody else. But there may be other mechanisms and other ways of transmission. And, investigators have found, for example, monkeypox virus in semen, but that doesn't mean that it's transmitted sexually. So at this point in time, I say it's not sexually transmitted, but it's an infection transmitted during sexual contact, or can be transmitted during sexual contact.
So it's primarily the skin-to-skin contact where a sex act is going to give you a lot of exposure that we really want to be most concerned about as we talk about it based on our current knowledge of transmission. Yes,
but there's also inanimate objects, for example, sexual toys that may be infected and transmitted. There may be towels, there may be that get infected with the lesions, there may be sheets that get infected with the lesions. So there may be a role also for inanimate objects that are leading to transmission. That doesn't mean, however, if I'm sitting in the subway or in a plane next to somebody with smallpox, with monkeypox, that doesn't mean I'm going to get infected just by sitting there.
Okay, that's important. Let's talk about symptoms, and we are going to come back to transmission again in a moment, but let's talk about symptoms for a second. Symptoms are very similar to smallpox. Most of us have not dealt with smallpox or seen someone who has it. Can you describe to us what those symptoms are?
So what people complain about is, there's a rash, and that's the characteristic. The lesions are very characteristic, but also at the beginning can look like anything. They could be macules, papules, vesicles. So if you have a lesion in the skin, especially in your genital area, you should get attention, but not because of monkeypox. Anybody with a genital lesion should get attention. The problem is, frequently we don't know we have a genital lesion. Now, one characteristic of these lesions is they tend to be painful. What I hear from patients is very significantly painful lesions. So having a painful lesion in your genital areas or in other areas exposed to in contact with somebody else should prompt attention. Then the other characteristic that we see is malaise, fever, and very importantly also a lymphadenopathy, growing of the lymph nodes in the region that is impacted. Could be in the groin, could be in the neck, depending on where the point of contact is. Finally, a lot of patients are complaining either of oral pain or of rectal pain, significant rectal pain, significant pain at urination. So again, not comfortable to have those lesions. And that what we're seeing with this virus is we're not seeing mortality, but we're seeing significant morbidity as a result of painful lesions and pain at the site of those lesions.
And can you start with one lesion? Suppose I had one on my hand. Would I anticipate that I might see them start to crop up somewhere else as well, or are they going to be connected?
They may or they may not. And part of it may be exactly who you are. During the prairie dog outbreak, for example, there was a family in which the older parent had been vaccinated against smallpox. Again, if you're 50 and older, you probably were vaccinated against smallpox because vaccination in this country stopped in 1972. If you're younger than 50, then you haven't been vaccinated. But if you've been vaccinated, you may have some degree of protection against this virus. What that means is that, in that case, that outbreak, the vaccinated individual had a few lesions, very few lesions. It wasn't totally protected, but it had maybe one or two lesions, while some of the family members that hadn't been vaccinated had multiple other lesions. So the immune system is going to play a role clearly in your degree of immunity to how many lesions you have. You may only have very, very few lesions. Now, one thing that is important is, and we've already seen a couple of cases, you may have a lesion in your hand, and then you may touch your mucosal membranes, including your eye, and then inoculate your eye, and then you'll have a lesion there. So, again, the contact, the skin-to-skin contact may be by yourself, right? You may touch your genital lesion and then touch your hand or your arm or your face and get lesions that way.
Okay, that's good to point out. Let's talk about the incubation period. You and I are so used to talking about COVID-19 in the past 2.5 years that we're used to this 2 to 3 day from exposure to onset of symptoms, maybe 5 days at the onset currently with our subvariants. Moving to monkeypox, though, there's a much longer incubation period that we're talking about, and then kind of this flu-like prodrome syndrome time period. Can you walk us through that timing?
Yeah, it's really, it has been hard in all these cases to know exactly the incubation period. But in general, we talk about, between 5 and 21 days incubation period, frequently 10 to 14 days incubation period. So somebody could be exposed and then not have lesions until 1 or 2 weeks after they've been exposed. And that's, again, if you have multiple sexual contacts, if you go to a rave or to go to a party with multiple contacts with individuals, you may not necessarily know who was the person that infected you.
Okay. That, from an infectious disease perspective, becomes incredibly hard for prevention and transmission when we have such a long period of time where someone can be asymptomatic. You already alluded to the fact that mortality seems very rare. It's about 1% from what we've seen previously with monkeypox, but some people are more at risk. Can you talk through some of those more at-risk groups for mortality associated with monkeypox?
Well, first of all, let's say that in this outbreak, I've yet to hear of any deaths. So the mortality may be even less than 1% because we have already, over 16,000 cases globally and no deaths. So the mortality may be a lot lower than 1%, but the morbidity, as I said, is very, very significant. However, primarily the cases we're seeing are young, healthy individuals, right? Men in their 30s, 40s. But if this starts to get into immunosuppressed patients, and we're seeing an increasing number of people living with HIV and advanced immunosuppression who are not on therapy, so persons with HIV, if it gets into pregnant women, and there's already been a case in a pregnant woman in this country, if it gets into children, those are the populations that traditionally tend to have very severe disease or are more likely to have severe disease when they get monkeypox.
Okay. We can hope that it does not hit a lot of people with immunosuppression, and certainly we want to make sure people know who's most at risk. And we're going to talk about immunizations in a second. Suppose I believe that I have had an exposure, I have a suspect exposure. Do I go ahead and start isolating myself prior to being tested, or do I need to wait until I get tested in order to isolate?
Well, the most important thing is clearly isolation, but I would say because of the way that it's being transmitted, isolation to me would mean, not having sexual contact, not having, intimate skin-to-skin contact with other individuals once you've been exposed, because you may potentially transmit to others and you may not know it. I think once you have lesions, it's important to test individuals. And we know that you need to have a lesion that is actually ideally scrapable in order to test, because, if you just swab a lesion that is just a macula, or it may not necessarily isolate, you may not be able to detect the virus. But once you have a lesion, it's important to be tested. And again, because of how this virus is being transmitted, many of the patients we're seeing not only have monkeypox, but they also have syphilis or herpes or some other sexually transmitted infection. So you need to be tested not only for monkeypox, but for other sexually transmitted infections. And then it's really important that if, that you clearly, isolate and you don't get in contact with others, primarily skin-to-skin contact, because, for example, the 2 cases we've seen in our country in children, one of them in California, is because they were living in the house of somebody who had monkeypox, and they were in contact with, they were being, hugged, kissed, and then those things then touched, and that's how transmission occurred.
Okay. If we do have to go into any form of isolation beyond just not having sexual activity, is it about 3 weeks that we're talking about for monkeypox?
Roughly, it's about 3 weeks, but again, with treatment, it may be less.
Okay. And if symptoms do start to appear, what is the best suggestion about ways to take care of the fact that they do hurt, the lesions hurt, or they are itchy? What should someone be doing?
Well, again, the management really requires to be seen. A physician who has experience in management sexually transmitted infections should see you, and then they can prescribe analgesics, they can prescribe, sitz baths. There are multiple other things you can do. Again, I want to emphasize, we haven't seen mortality, but the morbidity is significant, and management of the symptoms is going to be very important.
Beyond immunizations, what would I need to do to prevent myself from getting monkeypox right now, where we do see cases circulating?
Well, again, it's number one is getting information. I think it's very important for people to get information. But number two is also to realize that at the general population level, at this point, this is really not a concern. I was asked the other day, after the 2 cases of children in this country, saying, should parents be concerned about monkeypox among their children as we're going back to school? And I said, you need to be informed. But honestly, at this time in my life, if I had young children, I would be more concerned about them getting shot in school and you know, gun violence than monkeypox. We have to put things in perspective. And I think we have to realize that the risk of monkeypox in the general population at this point in time is extremely, extremely low. Now, if you belong to the, you know, gay, you're a gay or bisexual man, you have multiple sex partners, I think you need to really get informed, and you really need to realize that the most important thing you need to do is to get vaccinated. And the problem we're having right now is we don't have enough vaccines in our country. So we're trying to, there's more, it reminds me about the early days of COVID, where we had a lot of people who wanted to get vaccinated and not enough vaccines. This is being slowly resolved, and I think over the next several weeks, we'll get more and more vaccines in our country. But at this present time, the number of vaccines available simply is not sufficient for the number of people that want to get vaccinated.
That's 100% correct. And let's go through some of those numbers real fast. Currently, there are 2 vaccinations approved in the United States, but they have very limited availability, as Dr. Del Rio was letting everyone know. These vaccines can be used for both post-exposure prophylaxis. So I know I've had an exposure, or I believe I've had one, and I can use it in a way to reduce my severity of symptoms, but also for prevention. So very limited numbers have been distributed across the United States. So far, around 9,600 vaccinations have been delivered, but there are 323,000 vaccines being delivered to the states, and another 800,000 that are ready or almost ready for delivery. So that's a large number of vaccinations coming our way, even though it has not felt like, and it has not been enough lately.
Let me just make a couple of comments there. There are 2 vaccines indeed. One is the Janus vaccine, and the other one is the ACAM 2000 vaccine. They were both developed as part of the counterterrorism, bioterrorism initiatives in order to get us ready for a smallpox outbreak. They were not thought about for monkeypox. Now, the Janus vaccine is indicated, it has approval for the prevention of smallpox and monkeypox in adults 18 years of age and older. And that, to me, is the preferred vaccine for the prevention of monkeypox. The ACAM 2000 vaccine, is a vaccine that is the first one, the Janus, is an inactivated virus vaccine. The ACAM 2000 vaccine is it's a vaccine with a live attenuated vaccinia virus. And this vaccine is approved for the prevention of smallpox, but is not approved for the prevention of monkeypox. And that little difference is important, because if we were to use the ACAM 2000 vaccine, then you need to do a specific consent with the individual, because you're giving a vaccine outside the indication. If you're using the Janus vaccine, you don't need to do a special consent because it's approved for monkeypox. Now, the Janus vaccine has, because it's a live activated vaccine, has significant side effects, has significant potential side effects. And it's a vaccine that I would be very hesitant to give to people with immunosuppressed, for example, persons with HIV, pregnant women. The ACAM 2000 vaccine can cause myocarditis, can cause pericarditis, and other side effects, while the Janus vaccine is a much safer vaccine. So the preferential vaccine to administer is a Janus vaccine, and that's the one that currently is being administered. There is there's people saying, well, why don't we use also the ACAM 2000 vaccine? And there's a very interesting and significant debate about, well, at what point in time do we release the ACAM vaccine?
So all of these numbers that I provided are the Janus or the TPOX vaccination.
What's that?
So are all the numbers that I provided earlier probably the TPOX or the Janus vaccine?
Janus, yeah, it's a Janus vaccine. Yeah, the TPOX is actually the drug.
Okay.
TPOX is the drug for the treatment, is tecovirimat, and that's an antiviral drug. That's a different animal, basically.
Okay. All right. Thank you. Thank you for correcting me on that. Let's stick with the vaccinations for a moment. So it's been advised that people who've been exposed but haven't had a smallpox vaccination in the last 3 years get a vaccine. And timing wise, and this is going to be really difficult given the numbers we've been talking about, timing wise, if you've been exposed but haven't received the smallpox vaccination, again, in the last 3 years, you should try to get a vaccination in the next 4 days after exposure, or no later than 2 weeks, to try to minimize symptoms. How hard is that right now in the United States?
It's pretty hard. We simply, as I said, don't have at this point in time enough vaccine. There's a lot of prioritization being given, trying to reach the most at-risk individuals. So, it's not like you can just walk into a health department and say, I want to be vaccinated. There simply is not enough vaccine. And that's why we have to talk about the other option. The other therapeutic option is tecovirimat, which is an antiviral drug. But again, tecovirimat is a drug that currently it's under an expanded access use. In other words, a compassionate use for the treatment of monkeypox. Is not a drug for which we have a lot of human experience, but is the one drug that we are trying to use and trying to treat in people who already have disease.
Okay, all right. And for prevention, if I'm in an at-risk group, who is that who might now currently be eligible for vaccination? Because what we know is when vaccines are limited in number, and until we get more, we're going to give it to our highest risk populations first. Who is that?
So depending, each state and local health department is making their prioritization list. But in general, what we're doing, in our country at large and internationally also, a significant percentage of individuals with monkeypox are people living with HIV. So persons with HIV with low CD4 counts or not an antiretroviral therapy would be one priority group because they are at risk of more severe disease. Then we're also using as a priority, we're also giving it to people with HIV or who have a recent sexually transmitted infection or more than one sexual partner, or persons at risk of HIV who are receiving pre-exposure prophylaxis with medications to prevent them from getting HIV. That means that they have multiple sex partners and could be at risk of infection with monkeypox.
And do you see that eligibility expanding when more vaccinations are available?
Oh, absolutely. I see that eligibility expanding, but I still hopefully would like to see the vaccine initially being administered primarily, given 99.1% of our cases in the U.S. are among men, and of those, most of them are gay and bisexual men. We don't have really a lot of data on transgender women, and but to me the priorities will be gay and bisexual men and transgender women as the number one priority populations that I want to vaccinate.
Okay. And in Atlanta, which is a little different than the outbreak that we're seeing in New York, the vast majority of cases have been among gay and bisexual men who are Black or Latino. And we are having trouble getting the vaccination into communities that are going to be the highest risk beyond gay and bisexual men in Atlanta. So we are working on that in the Atlanta metro area in particular.
Yeah, we have to focus on health equity. And I worry that, the way the vaccines are being done, those that are savvier with the internet, right. For example, Fulton County had 400 vaccines the other day. And I think, they put in social media, they put the appointments there. And I think in 3 minutes, the appointments were full. And I don't know the breakdown, but I worry that it's going to be mostly white individuals that are savvy with the internet getting their vaccines, and we're not getting it to the populations that need them the most. The state of Georgia has worked with us, and we're very pleased that, for example, at Grady, the infectious disease program, the HIV clinic here in Atlanta that we run, is receiving an allocation of vaccines directly, because we think that's a really important population to get. It's HIV population in a very large clinic, and the great majority of our patients are African American and are underserved, are poor or very low socioeconomic status. So I'm really glad that the state has put that as a focus of where to get the vaccine.
Yeah, I was very excited when I heard that as well. And my understanding is that is coming very, very quickly to the infection.
Oh, we're vaccinating this week.
Great. That's fantastic to hear. Real fast to finish talking about vaccinations, it's a 2 vaccine series, correct? And can you tell us the spacing on that?
Well, again, the Janus vaccine is 2 vaccines that are separated by 4 weeks. It can be a little less, a little more. The ACAM 2000 is 1 dose vaccine.
Okay.
But again, you administered the ACAM 2000, you administered with the bifurcated needle, and this is the way we used to administer the vaccine for smallpox. Mm-hmm. So it's different than a vaccine that you give intramuscularly or subcutaneously, like many of other vaccines. In fact, I have here in my office, Stan Foster, one of the leaders that eradicated smallpox, gave me this bifurcated needle. And this is what you use to inoculate against smallpox, and this is what you use for the ACAM 2000. So you have to dip the needle that has a little sort of bifurcated tip. You dip the needle in the fluid, and then you sort of do multiple hits in the arm as part of the inoculation. So it's a different vaccine to administer. It requires training of how to do it, et cetera.
Those of us over a certain age certainly know what those look like, because we've got them on our arms right now. What does that smallpox vaccination that some of us received when we were younger confer for immunity with monkeypox? Are we getting some level of protection or no?
Again, we think we are, and from other outbreaks we think we are, but we don't know about the current outbreak. Is it that we're seeing mostly younger individuals because that's the network, but somehow it seems like if you look at the median age, looks like people who've been vaccinated are less likely to get infected. Maybe they're less likely to being part of those networks and not getting infected. So it's hard to know. But to me, there has to be some degree of protection. The problem is, I received my smallpox vaccine 60 years ago, so I'm not sure how much immunity I have.
Right. All right, you and I both last night on social media put out a request for questions about monkeypox. And when I reviewed what people wanted to know, I repeatedly saw questions related to how worried should I be? And you did a great job a few minutes ago of talking about if you're sending a child to school this fall, what you might need to be more worried about than monkeypox. However, people are really questioning, do I need to worry about this in addition to COVID-19, in addition to school shootings, in addition to all these other things I worry about? And so let's talk for a moment about that, because since monkeypox started to sicken thousands of people worldwide just this spring, two questions have consistently kind of loomed that we're not really sure about the answers. Why is this virus that has never managed to spread much beyond where it normally sits at an endemic level in certain areas of Central and Western Africa, why is this causing now a big outbreak globally? So that's our first question.
Well, let me start by going back a little bit. And I would say the main question and the main thing we need to address is, why have we not worried about monkeypox for years? That disease has been in Africa for a long time. A lot of the questions that we have now about treatment, about the vaccination, we could have the answers now if we had addressed monkeypox in Africa or during all these years. We could have set up the clinical trials. We could have done many of the things. I mean, today I was talking to the FDA and they were saying, we'll have no clinical data on tecovirimat in humans. Well, we could have had that data if we had done the studies. So again, it emphasizes the importance of global health. And if we had paid attention to monkeypox in Africa and done the right things, we would be in a very different situation. So part of the problem is this is a reminder that what happens in Africa should matter to all of us. And I think global health, again, over and over is showing us in this, China with SARS-CoV-2, now Africa with monkeypox. We have to be concerned when diseases occur in other places, and we cannot make the mistake of ignoring global health. The number two issue is we have planes. We go to places today. I've been reading about the expedition, the Edmund Hillary expedition to Everest. I mean, they left England on ship, and they traveled for 2 months to get to Calcutta, and then they traveled by train to get to Nepal, and then go up the mountain. I mean, today I can get on a plane here, fly to Dubai, and then fly to Nepal and be there in what, 20 hours, 24 hours? It's we're traveling, we're moving around a lot. And as you saw, tourism, it has gone back to where it was before. And then I think something that played a role is that we had been all in lockdowns and isolation over the last 2.5 years. And I think a lot of young people all of a sudden said, let's party. And, there was this huge rave in the Canary Islands, and there have been all these other activities. So I think it's a confluence of factors that has led to this disease. It's not just one thing.
And so do you think that the social behavior part of it, is that why we're seeing this really hitting highly interconnected sexual networks more than we're seeing it hit anywhere else right now?
Absolutely. That's what's going on right now. But that doesn't mean that it's going to stay there, right?
Right.
Because those individuals will then, have contact with other individuals. And to think about, I think about the early years of HIV. You and I are, again, we're showing our age, but HIV at the beginning was the disease of the four H's, right? The hemophiliacs and the Haitians and the, heroin users and the homosexuals, yet HIV didn't stay there. It impacted, other individuals, it impacted pregnant women, it impacted the general population, children. So we have to realize that we have a small window that is closing rapidly to try to contain this infection and not let it spill over more and transmit to other individuals. And that's when people say, how concerned I need to be? I said, you need to be very concerned because you need to help. This morning, the Biden administration, there was some communication saying controlling monkeypox may require, $5 to $6 to $7 billion in funding. We need to call our representatives. We need to say, please give that money. If we don't do the right things right now, and we don't give the resources right now to control this outbreak, it's going to be very hard and much more expensive to control it later.
Absolutely. And just like you pointed out so eloquently, we must pay attention to global health. We must not get lax and say that this is a gay man's disease. This is not the beginning of HIV. That's not what we're talking about here. And in fact, the WHO on Monday cautioned against complacency in this rapidly escalating monkeypox outbreak, saying that there's no guarantee it will not spread beyond communities that we're currently seeing it in. And as of this morning, we have reported cases on 5 college campuses in the United States, in county jails, in 1 pregnant person who luckily is doing well, as is the baby, and in 2 kids. So we know it's already outside of these networks, although at a much, much lower number.
So college campus is a great place for a lot of transmission to occur because there's a lot of sexual activity and a lot of contact of individuals. So yeah, I worry about that. But again, I go back to, this being declared a public health emergency of international concern, which is what we started by WHO. WHO had a meeting with this committee that advises the Director General on this. And the committee voted, 6 members voted in favor of declaring a public health emergency and 9 were against it. And
Right.
The Director General, despite this vote, went ahead and declared, and I thought it was the right decision. But among the 9 members that voted against it, many of them said, well, there's no need to declare a public health emergency of international concern because it's only affected gay men and is not killing individuals. It's a big mistake, and I'm really disappointed that those people are advising WHO because they're clearly not the right advisors. But I want to recognize, the leadership of Dr. Tedros of saying, despite that advice, I am proceeding with declaring this a public health emergency of international concern. Now, this is difficult times. There's no other time in history that I recall that we had 2 infections, 2 viruses circulating simultaneously with public health emergency of international concern. Now we have SARS-CoV-2 and now we have monkeypox. And that is incredibly stressful. It's stressful for all those of us in infectious disease and epidemiology and global health, but it's really stressful for the general population, and particularly worry about young individuals that now have yet another virus to worry about. And again, this is something that I think will have a significant impact in the mental health of the population. So I also want to emphasize the importance that we pay attention to mental health because people are tired of public health emergencies.
Absolutely. And this constant, I have to figure out my risk, where I go and what I do is hard. It's hard with COVID-19. It's hard to figure out what, for SARS-CoV-2, it's hard when you add something else on top of that. And so this is a lot to be asking of the public, to try to figure out your own personal risk at any given time, at any given moment of what it is you're doing.
And that's why I think we have a very important role in the sessions we have about giving information, because a lot of people, what they want is they want to hear information and they want to hear reassurance from experts like you and me about what to do and how to proceed.
Thank you for that. So we're going to go back to COVID-19 for a moment and remind everyone that almost half of the United States is in a location where indoor masking is highly recommended at this point in time. This is not forever. This is where we are again. And so we ask that you please engage with that protection for both you and those that you love. And as far as monkeypox goes, please do not panic, but please remain vigilant, recognizing that the situation is rapidly evolving, and that there is much work to be done, most of which starts with good information, which is what Dr. Carlos Del Rio and I have tried to bring to you today. And we will be back as we get more information about where vaccines are and how to get them and who is currently eligible. So thank you, Dr. Del Rio, so much for being with me today, and thank you for everyone who's watching.